On in Learn First Aid with me, we are starting with the neural development of the block neurology. And the first thing that we're going to study is the neural development. So what happens is that your body makes notochord. That notochord, its function is to induce the overlying ectoderm over it and convert that ectoderm into neuroectoderm, and that neuroectoderm then shapes itself into neural plate. So the job of the notochord is done now. So notochord will now be found as a rudimentary structure in the adult, and what you call it nucleus pulposus, which is present between the intervertebral disc. Now, what happens to the neuroectoderm, which ended up becoming neural plate, is that neural plate, it gives rise to two structures. Number one is the neural tube, and number two is the neural crest cells. Now, that neural tube, it further has two plates. It will divide into two plates that are alar plate or basal plates, whatever you call it. Now, all people have basic sense. So alar plate, they're sensory in nature, and all people have bones. So they will be induced by bone morphogenetic protein. Second we have is the basal plate. So sonic computers and Sony stuff is very basic. So basal plate, they're induced by sonic hedgehog. And since alar plate is sensory, basal plate automatically is going to be motor. And also motors are very basic. Okay, so they have same orientation as spinal cord. Spinal cord have the same orientation, like alar plate is dorsal and basal plate is ventral. That is with the neural development. Now moving toward the regionalization of a neural tube. Now that neural tube, it would further be divided into certain regions. The first region is telencephalon. So you can remember it like there used to be a telephone. That was the first thing that came out in the form of a phone that we carry these days. So telencephalon is the first part. When we have a telephone, what do? We dial some number. So diencephalon is the second part of the neural tube. Then rest of them are arranged alphabetically. Now you know that the third part is mesencephalon, then metencephalon, and the myelencephalon. What's more important than remembering the walls or these vesicles is that what they make up of an adult, like what are the adult derivatives. So first of all, we have three basic divisions of your neural tube. Number one is prosencephalon, which is the forebrain. Second is midbrain. Third is hindbrain. So first of all, that neural tube, it makes three bumps in it. First is prosencephalon, second is mesencephalon, and third is rhombencephalon. Now that prosencephalon, you can remember is that as past, forebrain is prosencephalon past, and in past we used to have telephones like that. So prosencephalon is divided into telencephalon and diencephalon. Then midbrain is mesencephalon, and hindbrain then again divides into metencephalon and myelencephalon. Now that telencephalon, it is further divided into two big buds like structures. This is the only structure that is going to be divided. Now if you have two bugs, so adult derivatives are going to have stuff that are present bilaterally. For example, cerebral hemisphere. So you have the hemisphere on the right side and on the left side. So the walls of these telencephalon, they're going to make cerebral hemisphere, and there are a lot in basal ganglia as well. So basal ganglia, and the cavities which are present in the telencephalon would be again two cavities. There would be two lateral ventricles. We only have two lateral ventricles, rest of the ventricles are alone. So the two lateral ventricles, they're derived from the two buds, and two buds are from where? From telencephalon. Next we have is diencephalon. Now below telencephalon is diencephalon, and under the cerebral hemispheres you're going to find thalamus, you're going to find hypothalamus, and because eye is called the continuation of the brain, you're going to find retina as well. And what cavity below the lateral ventricle is? You have the third ventricle. So that is how you know that below the lateral ventricle, third ventricle is there, and third ventricle is formed by the cavity of diencephalon. Moving down, we're done with prosencephalon. Okay, prosencephalon, telencephalon into cerebral hemispheres and basal ganglia and lateral ventricles. Then we have diencephalon. Diencephalon is going to make thalamus, hypothalamus, retina, and third ventricle. Now what are we going to do with the mesencephalon, which is midbrain? Easy peasy. Mesencephalon, midbrain, and cavities. What is connecting lateral and third ventricle above with the upper part of the fourth ventricle and lower part of the fourth ventricle below. There is a midline structure between these ventricles and cavities, and what is that midline structure called? Cerebral aqueduct that connect these two ventricles. So mesencephaline wall is converted into midbrain, and the cavity and ends up becoming the cerebral aqueduct. Now rhombencephalon, hindbrain. In hindbrain, we have metencephalon and myelencephalon. Now, that metencephalon, it makes pons. Below the midbrain is pons, and it also makes cerebellum alongside the pons, the cerebellum on the lateral sides of it, and upper part of fourth ventricle is made. And then we have myelencephalon. The last part of your brain is medulla. Not your brain exactly, but in anatomy. Going down, you're going to find medulla, and you're going to find the lower part of fourth ventricle, that is going to be its cavity. So now, according to the anatomy, we know that what were the vesicles, what were the secondary vesicles, and what became the adult derivatives of those. You just have to keep in mind that of secondary vesicles, you have two parts, walls and cavities, and walls are going to make what, and cavities are going to make what. For example, if I trick you, mesencephalon, the cavity of mesencephalon finds what? Cerebral aqueduct. The walls of telencephalon makes what? Yup, telencephalon have two buds, cerebral hemisphere, two buds, basal ganglia feels to be fixed in those cerebral hemisphere. So we have telencephalon divided into cerebral hemisphere and basal ganglia. Moving further, we have the origins of central and peripheral nervous system. Now what happens is that there are neuroepithelial cells in the neural tube. These neuroepithelial cells, they make CNS neurons, they make CNS glial cells. What are the glial cells? Glial cells are the good helping cells. They help your neurons do stuff. So astrocytes, oligodendrocytes, ependymal cell, these are all the glial cells. Next we have is the neural crest. Okay, so that neural crest, it makes peripheral nervous system neurons, in which we have dorsal root ganglia, autonomic ganglia, all the sympathetic, parasympathetic, indirect nerves, and then we have again the glial cells of the peripheral nervous system, which is Schwann and satellite cells, and adrenal medulla. It is also made up of neural crest cells. Then third we have is the mesoderm, the microglia, which is the protector of your nervous system. Macrophages, it is made up of mesoderm. Okay, so the main chunk of this is that neuroepithelia makes central nervous system neurons and glial cells, and neural crest cells, they make peripheral nervous system. So if you have some problem that you're going to encounter in your peripheral nervous system, for example, you have the problem with the neurons in the gut, that happens in the Hirschsprung disease. Okay, so you have a problem with the peripheral nervous system. So origin of that problem is going to be what? Neural crest cells, because we have seen what? We have seen that if they will ask that what is the embryological problem in Hirschsprung disease, we say that it is the defect in the migration of neural crest cells. Now, if there is a problem with central nervous system neuron, for example, we end up getting meninges out of the body, like what happens in spina bifida, etc. So it is the problem of neural tube. So there we have the neural tube defect. All right. Next we have is neural tube defects, very commonly seen in the world, where folic acid is not, people have not yet befriended folic acid, and people do not go for prenatal screenings and stuff like that. Neural tube defects are very common. Now what happens on those defects? As the name suggests, that something is going to be messed up in the neural tube. What that something is going to be? So normally what happens is that the neuropores, they fuse by the 4th week of development. So when they don't fuse, when they fail to fuse by the 4th week of development, what happens is that there remains a persistent connection between amniotic cavity and spinal canal. All right, and this connection is what results into that neural tube defect. It is associated with diabetes, it is associated with folate deficiency during pregnancy. Now, how can you detect it during pregnancy? How can you detect it? If you do the testing, you will have increased alpha fetoprotein in amniotic fluid and serum, except for spina bifida occulta, like it is the mild form, so you're going to get the normal AFP. And along with it, you will have the increased acetylcholinesterase in amniotic fluid. It is also helpful confirmatory test. So normally what happens is that normally acetylcholinesterase is absent from amniotic fluid. Okay, there is no acetylcholinesterase in the amniotic fluid, because why? Acetylcholinesterase has nothing to do with the amniotic fluid. It is present in the spinal canal. So if you're finding acetylcholinesterase in the amniotic fluid, it means that it is getting leaked from somewhere. There is a place from where it is coming in. And what is that place? Spinal canal. Spinal canal has abundant acetylcholinesterase present in it. So what this signal towards? It signal towards a failed fusion between amniotic canal and amniotic cavity and spinal canal. Okay, so there is a pathway from which these things are leaking. Again, increase alpha-fetoprotein and increase acetylcholinesterase in amniotic fluid. So now amniotic fluid have a connection with the spinal canal, so it is going to have increased stuff in it. Okay, that is why you have to remember that in neural tube defects you have increase both of those parameters. Now talking about or moving towards the types, we have spina bifida occulta. What happens is that there is a caudal neuropore, it fails to close, but there is no herniation. Okay, it is usually seen at lower vertebral levels, dura is intact, and there might be a tuft of hair or skin dimple at the level of the bony defect, nothing else. Okay, phylum terminalis, the thickened end, it is fine. It is low-lying conus medullaris is there, it is fine. Okay, next we have is meningocele. Now in meningocele, what happens at the meninges, they herniate through a bony defect. Okay, but there is no neural tissue involved. In myelomeningocele, now myelo is the neural tissue. Now meninges and neural tissue, they are both herniating through that bony defect. Myeloschisis is also known as reschisis. What it is, it basically is that you have exposed, unfused neural tissue without skin or meningeal covering. So it is the scary presentation. We're going to see a baby with neural tissue and there's no skin, there's no meningeal covering. Okay, it is like gastroschisis that we see in GIT. Anencephaly is what happens now is there's a failure of rostral neuropore to close. There would be no forebrain form, open calvarium, and in clinical finding you are going to see polyhydramnios because there is no swallowing center in the brain. Nothing is being swallowed. Everything is being piled up in the center, so that is going to increase your amniotic fluid and make the polyhydramnios. All right, so these are the further types of your neural tube defects. Now you have open neural tube defects, which we have studied over here, and these are the defects of your primary neurulation. These are we basically have two types of neural tube defects. We have open neural tube defects, which are the defects of primary neurulation, and they're like Chiari malformation, myeloschisis. Okay, something is wrong with the primary neurulation. And then we have the second neurulation defect, which are closed neural tube defect, and they're confined to the spinal cord, and they include myelomeningocele, etc. Okay, so below them are some diagrams which you can see that in normal everything is in place. In occulta, tuft of hair, in meningocele, that meninges coming out. In myelomeningocele, there would be neural tissue along with the meninges coming out. Take home message: neural tube defect. What fails to fuse? Neuropore. If caudal neuropore, it is spina bifida. If rostral neuropore, it is an encephaly. Okay, and they're coming out of bony defect. There is leaking happening, so you're going to have increased alpha-fetoprotein in amniotic fluid, and you're going to have increased acetylcholinesterase in amniotic fluid. Done. Next we have are the harrowing, scary, messy brain malformations. And obviously brain is the master of your body. If you have these malformations, it is incompatible with postnatal life, and if they survive, they're going to be profoundly disabled. All right, so there are two types of brain malformations. Number one is holoprosencephaly. As the name suggests that there is going to be one thing, holoprosencephaly. What one thing? What is that thing which is two in the brain? Hemispheres. So if you have holoprosencephaly, there is going to be just one hemisphere. What does that mean? It means that the forebrain, that is prosencephalon, it fails to divide into two secondary vesicles, that is telencephalon and diencephalon. So now the forebrain, it has failed to divide into two cerebral hemisphere, and that development field defect, it usually occur when around 3 to 4 weeks of development. Now what is it associated with? Sonic hedgehog mutation, because again they are related to your basal plate. It can also be seen in TAW syndrome, which is trisomy 13, and it can also be seen with fetal Gall syndrome. Now what it presents with, they're going to be one everything, like they're going to be monoventricular, they're going to be fused basal ganglia because you're not being divided into two vesicles, cleft lip and palate, There is going to be hypotelorism. The distance between both of your eyebrows is going to be decreased. Cyclopia is a very scary. You feel to have one eye. Okay, you're going to have proboscis, which is a tube-like extra nose. You're going to have increased risk for pituitary dysfunction, like diabetes insipidus and another hypogonadism type of structures. So the most scary condition you're going to study in medicine, when you will imagine it, is going to be holopresencephaly. Everything is going to be one hemisphere, fused basal ganglia, one eye, one extra nose. Okay, pituitary dysfunction, hypotelorism is also this is a horrible kind of condition, which is because failure for brain, it fails to fuse. Second we have is the lysencephaly. In what happens in the lysencephaly, that you do not have adequate neuronal migration. That because of lack of adequate neuronal migration, what happened is that the brain surface, it is going to lack the sulcus and gyrus. There are going to be no sulci and gyri, and there will be very smooth brain surface. Like imagine a brain surface without any sulcus and gyri, it is going to be smooth like baby skin that you have. So associated with what? Microcephaly, facial anomalies, and hydrocephalus. Obviously, if you're not going to have some sulcus where that water is going to do in a smooth surface, it is going to pile up, that is going to create hydrocephalus. And then again, because the sulci and gyri, they were giving some volume to your syphilis, volume to your brain, they are gone. So now microcephaly is happening, and brain is directly connected to your face, so facial anomalies are also present in this one condition. So lysencephaly is because of neuronal migration, and holopresencephaly because it somehow fails to fuse. Okay, so next we're going to have are the posterior fossa malformations. What happens in what do you have in posterior fossa? Like remember, in posterior fossa we can remember that there are pons, and then there are cerebellum. So now we basically have three malformations when it comes to posterior fossa. What are that? Number one is Chiari 1 malformation, number two is Chiari 2 malformation, and number three is Dandy-Walker malformation. Now I would have focused upon, okay, remember Chiari was something like that, but that is not how you're going to be tested on your UWorld. They are going to give you one or two feature, and they are going to expect for you to know that what are these things related with, why is this thing happening, what is the primary defect in XYZ situation. So it is not like you have to close your eyes and remember, okay, posterior fossa malformation has this and that. You have to know the things individually, and then you have to move forward with them. So Chiari 1 malformation, what happens is that your cerebral tonsils, they go below your foramen magnum. So there is ectopia of cerebellar tonsils, which means that ectopia of cerebral tonsils inferior to foramen magnum. It is usually asymptomatic in childhood, but when you become adult, it can go like headaches and cerebellar symptoms, and it is associated with spinal cavitation, for example, syringomyelia. So it is Chiari 1 malformation. It is the initial stages of the malformation, so it is not very serious, and there is only one defect. So it is Chiari 1 malformation. What is that defect? Just an ectopia. Ectopia of what and where? Ectopia of cerebellar tonsils below the foramen magnum. Bachchu mein, in childhood, it is fine, but when you grow up, you become an adult, it can present itself as headache and cerebellar symptoms. Now next we have is Chiari 2 malformations. Over here we have two problems. Number one is that your cerebellum, it is herniated, both the vermis and tonsils of the cerebellum and medulla through foramen magnum. Now they're herniated through foramen magnum. There is going to be non-communicating hydrocephalus, because now you have stopped a proper way of the ventricular fluid to flow. It is more severe in Chiari 1, obviously, and it usually present early in life. And what are its symptoms? Dysphagia, stridor, apnea, limb weakness, because now you are affecting the control center of the brain where these things are controlled, where the reflexes of these things are happening. But now you have a problem with them, so you're going to have experience dysphagia, stridor, apnea, limb weakness, and it is associated with myelomeningocele, which is usually lumbosacral. So the take-home point is that Chiari 1 malformation, ectopia of cerebral tonsils. Chiari 2 malformation, there is no ectopia, herniation of cerebellum, vermis and tonsils. Chiari 1, they were just tonsils. Chiari 2, vermis and tonsils along with medulla herniating through the foramen magnum. Next we have is the Dandy-Walker malformation. Now Dandy-Walker guy, he went extreme, and he's like, Okay, there would be no genesis of cerebellar vermis. Agenesis of cerebellar vermis happens here, and when there is no cerebellar vermis, the fourth ventricle will have a lot of place to grow. So they're going to be cystic enlargement of fourth ventricle that fills the enlarged posterior fossa, and it is also associated with non-communicating hydrocephalus and spina bifida. Okay, so Chiari 1, we have cerebellar tonsils. Chiari 2, we have cerebellar vermis and tonsil with medulla. Now, Dandy-Wacker, we have vermis. Okay, so all of the cerebellar parts are involved. Vermis and elongation, or you can say cystic enlargement of the fourth ventricle. So, now over here we have 3 posterior fossa malformations that we have remembered for now. Moving towards the next problem, now we are moving down the cerebellum and we have the spinal cord, we have syringomyelia. Syrinx is a cystic cavity within the central canal of spinal cord. What happens here is the fibers that are crossing an anterior white commissure spinothalamic tract, they're typically damaged first because they're the first to face this cavity, and in result we see the cape-like, which means the shoulders and arms in your clavicular area, bilateral loss of pain and temperature sensation in upper extremities, fine touch is preserved because it is carried by the other pathway dorsal column. It is also associated with Chiari 1 malformation because of low-lying cerebral tonsils. Scoliosis also causes it, and other congenital malformation. Acquired causes can include trauma or tumors, and most common location of syringomyelia is cervical, then thoracic, then lumbar in their usual pattern. Okay, below is the diagram of a guy who has lost sensations of pain and temperature at the effective dermatome, and anterior white commissure is compressed by the syrinx. Okay, because anterior white commissure, it is compressed by the cystic cavity that is made, so these are being expected. Okay, so in syringomyelia, the pattern of your symptoms is going to be like this. You're going to have upper extremity pain and temperature sensation loss. You're going to have upper extremity lower motor neuron because it would be above after the ganglion, and in lower extremity you're going to see upper motor neuron lesions, and you're going to have scoliosis. All of this constellation of symptom is going to make you or give you syringomyelia. Next we have is the tongue development. Okay, so you're like, tongue development from like straight from brain and spinal cord, we have jumped over the tongue development because pharyngeal arches are involved. Okay, so tongue development, what happens is that in pharyngeal arches we have the first pharyngeal arch. It forms the anterior 2/3 of the tongue, and sensations are carried via the V3, and taste is carried via CN7, which is facial nerve. So third and fourth pharyngeal arches, they form the posterior 1/3 of the tongue, sensation and taste mainly via glossopharyngeal nerve, and extreme posterior via vagus nerve. Now motor innervation is through via hypoglossal nerve to hypoglossus muscle, genioglossus and styloglossus muscles. And hypo depresses the tongue. Genioglossus, genie will make a wish by putting his tongue out, so that will be protruding tongue, genioglossus. And styloglossus, like moving the tongue in some style, sides of tongue upward and create a draw for swallowing, so styloglossus. Motor innervation is via cranial nerve 10 to palatoglossus. It elevates the posterior tongue during swallowing. After you're done with the initial going down and up and style, you have to put it posterior. So palatoglossus is posterior, and posterior of whole, it is basically carried by your vagus nerve. So that is tongue development. And in tongue development, what you have to remember is that anterior 2/3 first pharyngeal arch, posterior 1/3 third and fourth pharyngeal arch. Okay, we know the taste is carried by glossopharyngeal nerve, vagus nerve, solitary nucleus and facial nerve. Pain is carried by the mandibular branch of trigeminal nerve, glossopharyngeal and vagus nerve, and motor is by cranial nerve 10 and 12 that are hypoglossal and vagus nerve. Okay, and there's also a mnemonic mention that cranial 10 innervates palatinoglossus, but how I keep it in my mind is that palatoglossus is posterior, and everything posterior is being supplied basically by the vagus nerve. Okay, so we're done with the embryology. And in embryology, what we started with the neural tube development, regionalization of the neural tube, development of central and peripheral nervous systems. Then we moved forward towards the spinal tube defects, then brain malformations, then posterior fossa malformations, syringomyelia, tongue development. Now we're moving towards anatomy and physiology, and we will just study the types of neuron for today, and then we'll call it a day. Now, neurons are the powerhouse of your cell, like of your body. So they're signal transmitting cells of the nervous system, not powerhouse, we should call them communication center. They're like BBC media. They are permanent cells that do not divide in adulthood. They are signal relaying cells with dendrites, which receive the input. There are a lot of it. Cell bodies where they process it, and axons. There are not a lot of them, and they send output. Cell bodies and dendrites, they can be seen on nasal staining because they have rough endoplasmic reticulum. Rough endoplasmic reticulum is stained with the nasal stain, so you can see them both. But there is no rough endoplasmic reticulum present in the axon. You cannot see it. Neuron marker, neurofilament protein and synaptophysin. Like wherever, if they're explaining you a tumor where they're saying that we have found synaptophysin positive, and they will find that there is some kind of symptoms that are related to adrenal medulla. So adrenal medulla is also a neural crescent derivative. So you can get an idea of where the tumor is and what is the cell it is made up of and what is the origin of that cell, but by looking into its marker. So you should and must know the markers. Neuron marker is neurofilament protein and synaptophysin. Important thing about neuron, which you should remember, is that cell body axons does not have rough endoplasmic reticulum. You cannot stain it, you cannot see it. Dendrites and cell body, they do have rough endoplasmic reticulum. You can see them. Second we have is astrocyte. Astrocyte are the most common glial cell in the central nervous system. They are like stars of central nervous system. They provide physical support, they repair, the removal of excess neurotransmitter is on them. They are the component of blood-brain barrier, glycogen fuel reserve buffers. Their reactive gliosis happens in response to neural injury because obviously they're involved in repair. They're derived from neuroectoderm, and by which marker we can see astrocyte? GFAP. It is glial fibrillary acidic protein. So GFAP is glial. Astrocyte is also a glial cell. So GFAP, glial fibrillary acidic protein, is the marker for astrocyte. Next we have is the microglia, which protects you in a central nervous system. It is the phagocytic scavenger cell of central nervous system. It activates in response to tissue damage. There will be release of inflammatory mediators, nitric oxide, glutamate, and it is not readily discernible by nasal stain. You cannot see it that way. Okay, it is derived from mesoderm. HIV infected microglia, they fuse to form multinucleated giant cell in CNS seen in HIV associated dementia. Nodules effective microglia. So basically in HIV you also see CNS lymphoma, but if you see a kind of lesion where there's no, like, it is not lymphoma, but you see multinucleated giant cell, and they ask you that what are you going to see, like what is in these cells? These are microglias. These are HIV infected microglias which are fused to form the multinucleated giant cell. And last we have is the ependymal cells. So ependymal cells are the ciliated, simple columnar glial cell lining ventricles and central canal of spinal cord. The ependymal cells, they line the ventricles. Okay, the apical surface is covered by cilia, which circulate cerebrospinal fluid which is present in those ventricles, and microvilli, which help with CSF absorption. So they're also derived from neuroectoderm, and they're specialized ependymal cells which are choroid plexus. They produce cerebrospinal fluid. So neurons, what was the marker for neuron? Neurofilament protein, synaptophysin, astrocyte, GFAP. Microglia, we have, it is derived from mesoderm, and there are no marker as such. Ependymal cell, it is also derived from work. Neuroectoderm, it makes CSF. It have the cells which help in circulation and absorption of cerebral spinal fluid, and ependymal cells are ciliated, simple columnar cells. So if somebody asks you like, okay, sure, your respiratory system have cilia, does your brain have cilia? The answer is yes. Ependymal cells of your brain, of your central nervous system, they do have cilia. That's it for today. It's raining outside. We'll continue tomorrow with myelin and move forward from there with the physiology.